Hi, my name is Mike Pulcari. I'm one of the allergists at Alabama Allergy, and today we're talking about allergic asthma and how it is much more than a runny nose. And it's an appropriate time for us to be talking about it right now, since right now it's in the spring and everyone's allergies are raging. So with that in mind, let's dive right in. So today, the things that we're going to be covering are the difference between allergic and non-allergic asthma. We're going to go a little bit deeper, a little more in the weeds, and kind of talk about that Th2 inflammatory role in asthma and how different allergens can induce that. And then more importantly, from a practical standpoint, we'll talk about what we can actually do with this to kind of help patients as they go forward. That said, I kind of think about what Julie Andrews said in Sound of Music, where, let's start from the very beginning. It's a pretty good place to start. So with that in mind, I always like doing a little bit more of a historical type thing for this as well. So these guys are on here not just because one has an awesome beard and another guy has equally awesome glasses, but Charles Harrison Blackley was one of the first guys to kind of look into pollen as a role in allergies. So in around the 1870s, hay fever had already been described, and Charles Harrison Blackley was the first guy to think that maybe pollen is the cause of it. He would do what anyone would do if they thought pollen was the issue, where he took the pollen, put it in his eyes and had symptoms, put it in his nose and has symptoms, and then even did the first skin test and put it in abrasions in his skin and then developed hives. He took it one step further and actually put pollen on slides on a kite for our first pollen counter, established that pollen is traveling much higher up in the atmosphere, suggesting that pollen can travel for miles, which is why even if you cut down all the trees in your yard, you are still miserable come tree season. That said, all of that sounded like he was right on target, but there were a few things that he was just a little bit off. So I realize this is a long quote, but it's one of my favorite quotes because it's just humorous to kind of see where his thought process was, because he did notice that pollen was the problem, yet for some reason farmers who are, in that environment every single day seem to have the least amount of allergies. So he came up with two possible answers for this. The first possible answer was that, well, maybe farmers lack the overall mental disposition required to have allergic symptoms. Or maybe it's just that they're so immersed in it they get desensitized. So first idea was a little bit ridiculous, but the second one was spot on. And you can see this is from 1873 when they're kind of first starting to think about allergies with pollen and what they can actually do. From here, in the early 1900s, is where we started learning more about the immune system as a whole. And there was a guy named Clemens von Perquet who was a pediatric resident at the time, and he noticed that an odd phenomenon with infectious diseases, where it didn't seem to matter which infectious disease was, the incubation period was about the same from exposure to symptoms. Up until this point, everything was assumed that all of your symptoms came from the infection itself, the organism itself. But because there's this consistent pattern, he started thinking, well, maybe the immune system is responsible for this, and that's why there's that same kind of incubation period every time. So he actually wrote a paper on it, but it was too aggressive against the norms of the time. So because of that, he kind of just put it in a sealed envelope and sat on it for a couple of years until he started noticing this thing that he called serum sickness in 1905, where they were actually doing giving antibodies against diphtheria using horse serum. And he started noticing that people started having this issue, 1 week afterwards, the serum sickness that we know today type thing. So he was identifying these allergic reactions, but there wasn't a term for it. And that's where he really comes in. And he was the first person to coin the phrase allergy. So it comes from, everything comes from Greek. So it came from the Greek for allos, meaning other or different, and ergia, meaning, energy or actions or reactions. So it's basically an other reaction. So a reaction that you wouldn't expect, because you should not have all of your, eyes, nose, and lungs go nuts with something as innocuous as grass, but it does. And with that, we still haven't really come to the question of what actually is allergy. So you're going to see a few slides like this today in the presentation. I feel like as an immunologist, I'm kind of required by law to have some over-the-top, excessive, pathway type diagrams. So you'll see a few of these. But looking at this, the whole point in allergy is that it's not just exposure that first time. that first time you get exposed, which is in the left side of this panel, you have this sensitization phase. So the allergen, crosses your epithelial lining and interacts with the dendritic cell, which is the APC or antigen-presenting cell. That thing then goes to your lymph nodes. It activates T cells, shifts those T cells over to that Th2 inflammatory T cell, which we will talk a lot more depth in later. And it primes your B cells to make IgE. Once you have that IgE, it is loaded onto your mast cells, and now your mast cells are ready to rock. So all that stuff on the left side of the screen is that first time where you're really not having any big symptoms at that point in time. On the right side is when the next spring comes around, and now you see those allergens again, but this time your mast cells are ready with that IgE that's already loaded. So because of that, when it sees your allergen, the mast cell degranulates, causes histamine release, tryptase release, all that stuff that gives you all of those miserable symptoms with allergies that give me a job type thing. But otherwise, some things on this slide, we do see like, IL-4, IL-5, IL-13. Everyone loves talking about cytokines. But we'll cover those a little bit later, but those will come back again. So kind of diving more into that, Th1 versus Th2, this is kind of the way the nomenclature is kind of, shifting nowadays where, instead of just thinking of asthma as like allergic asthma, you might hear it called Th2 high asthma or Th2 low asthma. And it's just kind of describing the inflammatory process that is at the root cause of the problem. So you can kind of think of, there's more variations than just this, but you can kind of, bigger picture, split it into Th1 and Th2. Th1 is more of our, classic immune response that we think of. It's really more for like intracellular pathogens like viruses and intracellular bacteria like TB. This tends to be more IgG antibodies, whereas on the right you have that extracellular, so this is more originally designed to fight off, parasites and helminths and these big, complex extracellular organisms. So because of that, that's where the IgE, eosinophils, mast cells, all that stuff kind of come into role. The simpler version of the thing about that is on the left side is you have more like your protective, immune response, where on the right side, yes, it's protective against parasites and helminths, but we don't really have a big problem with parasites and helminths in this country. So instead, a lot of those same mediators then get distracted and start, acting out type thing and causing allergy. And as far as you're probably sitting there thinking, I said, what is allergy? And then threw a whole bunch of crazy letters and numbers at you type thing. I still haven't actually defined what is allergy. So a lot of people will ask, is allergy just a positive skin test or a positive blood test? Is it having that, runny nose, itchy eyes, red eyes every spring or when you're around cats and stuff? Or is it wheezing, coughing, chest tightness when you're around cats? And of course, the answer is yes. So the point of allergy is not just a test. It is a test with correlating symptoms. And as far as what are those correlating symptoms, it really depends on where your allergies are. So normally when I'm describing allergies to patients, I kind of describe like an atopic umbrella type thing. So under atopic diseases, you have all these different things. So you have allergic rhinitis, eczema, drug allergy, ABPA, food allergy, asthma. All of these things kind of tend to run together. So patients will always say like, oh, well, I'm allergic to peanuts. Are my kids going to be allergic to peanuts? I mean, not necessarily. It's having these things as a group tend to run in families. Now, yes, allergic rhinitis is much more uncommon, but you can have it where like you have allergic rhinitis and your kids have asthma and you have an uncle who has food allergies and your sister has eczema, and it can kind of, this cluster of atopic diseases can kind of run together from that. And as far as why these atopic diseases run together, it's location, location, location. These are all caused by these same cells and these same cytokines and the same inflammatory mechanisms. It just depends on where they are. So there's a lot of stuff on this figure, but the point of this is that you can see that the same mediators, like for example on the top, you have prostaglandins and leukotrienes and histamine that are all released, and they cause different things depending on where they are. So when that's released in your lungs, you have that bronchoconstriction and bronchospasm that you see in asthma. When it's in your intestine, you have increased intestinal hypermotility, which is what you would see with like an intestinal response and anaphylaxis. On the very top, you have vasodilation, which again, even that's a location type thing, where when it's in your nose, that vasodilation causes mucosal swelling with congestion, etc. If it's that same vasodilation in your skin, can lead to hives and redness, or in the most extreme scenarios, shock with anaphylaxis. But it's all caused by the same things, and just depends on where it is. So that is all like the background on allergies and type 2 inflammation and all that stuff that you really don't want to hear about anymore, because now we're going to start diving into asthma. So as you all probably know, asthma is kind of defined as that, bronchospasm, or smooth airway, bronchial smooth muscle, hyperactivity, that airway inflammation, and it should have some reversibility with a bronchodilator. So on this picture, this is kind of your normal airway on the left, your stable asthmatic airway in the center, and then your asthmatic airway that's having an acute reaction on the right. So the big thing is comparing the center airway to the left airway is that in the asthmatic airway, you're going to have some smooth muscle hypertrophy at baseline, but you're also going to have a much thicker, inflamed airway, where you have all of that junk that is in there that kind of just mucks the waters and makes things harder for you to breathe. That's at baseline. So the fact that you have that all the time is kind of that airway remodeling that people always talk about. On the right is then where you have the acute asthma attack, where you then have much more acute production of mucus and inflammatory issues inside the airway itself. Plus you have some smooth muscle tightening and spasm, which all locks down your airway and just gives you a much harder time breathing, as you can imagine. A more subtle thing that they actually kind of talk about, on this schematic they have it only on the acute exacerbation on the right side. You can kind of see that the alveoli are a little bit bigger than in the previous pictures. That's that air trapping. That can happen at baseline as well. I mean, if it makes sense, if you have stuff in the airway that is blocking passage of air, air's going to get stuck somewhere, and that's that air trapping or that obstructive picture. That's why when you'll see an x-ray of an asthmatic, they'll sometimes have more hyperlucent x-ray, or it's just much blacker than it normally is. They'll have the flattening of the diaphragms from all of that air trapping that's going on. Otherwise, so once we're inside asthma, you can divide this up into a whole bunch of different ways. But the bigger differentiations that we make is, allergic versus non-allergic. Classically, this was kind of called extrinsic versus intrinsic. It makes sense. Extrinsic would be allergic because it has an external trigger, whereas intrinsic, in theory, does not have that same external trigger, although it does. It's just not an allergic trigger. So with this, that allergic is also that Th2 high. So this kind of goes back to that slide we had before, where you have Th2 versus Th1. The allergic asthma is going to be Th2 high, so it's going to have more eosinophils, more mast cells, more IgE, more allergic triggers. And it makes sense that if you have more allergic triggers, you're going to have more atopic diseases as well. So these people will tend to have more allergic rhinitis, eczema, things of that nature. Whereas in the group on the right, this is that non-allergic. So they can still have rhinitis, but it's a little bit less common. It tends to be less eosinophils and more neutrophils, but really it can be a bigger mix. But the bigger thing with that non-allergic is that it doesn't have that big IgE trigger, that clear allergic trigger. The non-allergic, in general, tends to be later in onset, so this tends to be more of your adult onset asthma. It tends to be a lot more refractory to treatment, less responsive to just a straightforward inhaled corticosteroid. And these ones usually, for me, are a little bit more of a bear to treat. Whereas in general, the allergic tend to be more kids. In theory, they tend to be easier to treat. They should be more responsive to an inhaled steroid. And that's more of the in general, like comparing one versus the other. That said, there's a bit of a curveball when it comes to like younger kids, like that school age kid. Because with them, now the allergic asthma in younger kids tends to actually be more severe. And if anything, the more sensitizations they have to environmental allergies, the more severe their asthma tends to be. Which if you think like, the non-allergic asthma in a preschooler tends to be more of that, that viral-induced asthmatic where they're doing fine except for when they get sick and then they have that acute asthma flare. Those tend to be a little bit easier to treat and, milder compared to the kid who has that, raging dust mite allergy with tree allergies and cat allergies and asthma on top of that. And they're flaring all the time because their, exposures are year-round and all around them. But in general, as they get older, the allergic tends to be easier for us to treat. There we go. Otherwise, again, immunologist, big crazy schematics type thing. So here is yet one more that you can kind of dive deep into, but we're not going to go as deep into it. This is actually not just comparing allergic versus non-allergic. This is comparing allergic eosinophilic asthma versus non-allergic eosinophilic asthma. The reason why I have this one on here is not for you guys to remember the transcription factors like GATA3 and that are involved and using innate lymphoid cell type 2 versus Th2 cells. The bigger thing on this is if you look more downstream, you can see that a lot of the downstream cells that are involved in this are very similar. So it's still IL-5, IL-13, eosinophils, a lot of that same kind of inflammation, but the big difference with these two pathways is at the top of this. So at the top of this slide, on the left is that allergic asthma, and obviously it would then be triggered by allergens. But on the right, you have that non-allergic asthma. So even though it's the same inflammatory processes, the same alarmins like IL-25, IL-33, TSLP that are involved, the difference though is that on the right, it's triggered by non-allergic things. So these are those airway irritants, cigarette smoke, asbestos, especially like ship workers and stuff like that. Strong smells like perfumes can do this as well. The point is that this is why asthma can still look about the same, even though if it has a different trigger. The difference, though, is that if you have an allergic trigger, there's a lot more that I, as an allergist, can do for that. Whereas if your trigger is, strong smells, you can't, when you're going to church and the lady next to you has that really strong perfume, you can't tell her to leave. So a lot of those things are a little bit more out of your control. So focusing much more in on allergic asthma. This kind of goes back to the very beginning where we talked about how allergies are sensitization to an aeroallergens that can be proven by skin testing or blood testing and correlating symptoms. So in asthma, obviously those correlating symptoms would be asthma symptoms. So the example of this would be somebody who knows that when it's tree season and their allergies are going crazy, that their asthma also goes nuts. And then we do skin testing, and they have a proven sensitization to trees. That is that sensitization to an aeroallergen with correlating symptoms. The correlating symptoms becomes a little bit trickier when their allergy is something like dust mite, which we'll go over in a little bit, where dust mite is more or less everywhere, more or less all the time. But in these allergic asthmatics, from my standpoint, they do tend to have a higher FeNO, which is just another breathing test that we do in addition to spirometry, where when you have that asthmatic inflammation, the white blood cells that are involved will secrete more nitric oxide, and we can measure that with a test. But in this allergic asthma, like we said before, like the majority of kids have that allergic asthma. 80% of them have allergic asthma to at least one allergen. It's typically dust mite. And again, the more positives a kid has with asthma, the worse their asthma can be. This slide is pretty similar to one of the past ones we had. The reason why I have this one on here is kind of more of set up the frame, like the groundwork and the foundation for some interventions that we'll talk about later. But this is yet another schematic of airways and asthma versus normal. And you can see in the airway on the left, I mean, that airway is wide open and it looks pretty and there's not that much junk and it's just breathing through a tube at that point in time. Where in the asthmatic airway, you have that, smooth wall, spasm, that smooth wall, that wall remodeling where it's just thicker. You have increased inflammation inside the airway itself, increased mucus production. So instead of breathing through a tube, you're now more breathing through a straw that already has a little bit of milkshake in there as well. So it's just tough all the time. The reason why this is on there is, for me, especially for boards, I had to know that yes, IL-4 is more muscle spasm, IL-13 is more mucus production, etc. But the point for having this on here for the primary care physician or the hospitalist or anything like that is kind of understanding those three things on the right, where you have IL-4, IL-5, and IL-13. Those are the cytokines that have a very specific reaction, in the asthmatic airway. And the reason why it's important to highlight those is because those are the things that I have specific biologics against right now. So looking at IL-4 and IL-13, those are actually both targeted by dupilumab or Dupixent, which you've probably seen the commercials for it on TV for eczema. On the bottom you have that IL-5. There's lots of things that target IL-5. So you have mepolizumab, which is Nucala. You have reslizumab, which is Sincare. You have benralizumab, which is Fasenra. So all those things kind of target that same IL-5, and that's why we now have much fancier drugs that target the specific inflammation as opposed to just giving steroids, which kind of targets all of it at a cost. Because as we all know, steroids are magic, but they are the devil. But we'll come back to that, I'm sure. Anyways, we're going to start diving into the actual more specific allergy part of it. When I was making this presentation, I was telling myself that I was going to do you all a favor and not put a picture of a dust mite on there, but I couldn't resist, so sorry. But it's kind of gross, but it's kind of nice to know what these things actually do look like. So dust mites are everywhere. To be fair, they're not really everywhere. They do need 50% humidity to survive, but the thing is we live in Alabama. 50% humidity is everywhere all the time. The reason why they need that humidity is because that's how they actually get their water source. They actually passively absorb water from the air around them, as gross as this sounds. So because of that, if you were to live somewhere in a desert that was just a really arid climate where the humidity was plummeting, you wouldn't have a dust mite problem, but we do. To make things even grosser, the way these things actually survive is they feed off of dense skin cells, and the allergen that we are allergic to is actually the dust mite feces. That said, that allergen is a larger particle, so it is not constantly in the air, but it is very easily disturbed, and once it's disturbed, it stays airborne for 20 or 30 minutes, and that's when you kind of elicit symptoms from it. Because this is more or less everywhere, it's in our furniture, stuffed animals, bedding, obviously, particularly dusty areas, sure, but because it's more or less everywhere, these aren't really things that we typically associate with that acute asthma exacerbation. It's not like where you're cat allergic, I put a cat in your face and your asthma goes crazy. This is more of that chronic driver of inflammation. So this is kind of just always there, which is why I play such a huge role in not just asthma severity, but also development of asthma. So with this, going back to those kids where you said, the majority of kids, when they have asthma, it's that allergic asthma. 80% of children with asthma are sensitive to dust mite as well, which you compare that to the non-asthmatic children, only 30% are dust mite sensitive. So it is a pretty big driver of asthma development, which is seen when you're exposed to larger concentrations, 10 micrograms of dust mite allergen per gram of dust, because that's an easy metric to say, is, when you're exposed to that much, you have a 4.8 increase, relative risk of asthma development. And as far as where this dust mite live, and we often talk about things like, dust mite mattress covers and dust mite pillow covers, and we'll talk more about that on a future slide. The reason why we harp on the mattresses so much more is because there is so much more dust mite there. So this is from one study, which I believe it's on the next slide actually, where we talk about a study from Yale, where they actually took dust samples from different areas of the house of different people and measured the allergen content of those dust samples. For dust mites specifically, there was a 2.4 mics per gram of dust mite found in the living room, 4.3 in the bedroom, and then a whopping 18.4 in the mattress, which even if you're not really sure, well, what number is considered big type thing, the fact that there is, more than 4 times as much in your mattress than in your bedroom and about 9 times as much in your mattress versus the living room should really kind of hammer home the point that these things live in your mattress, and that's why we talk about mattress covers. This is just, we're not talking a whole lot about these two studies. This is kind of just really hammering home the point that dust mites matter for asthma. So the study on the left was actually a study with kids where they, at birth and then periodically would kind of measure their exposure to dust mite allergen. And they would kind of follow them, longitudinally to see when there was their first episode of wheezing. And what you can see is, the higher dust mite exposure, the earlier that first episode of wheezing was. Now, obviously, it's not a guarantee where if you have dust mite exposure, you're automatically going to wheeze. But if you are somebody who's already, has a family history, already predisposed for asthma, and you have that dust mite exposure, it can kind of slide that first onset to a much younger age. The study on the right is actually with adults. So this was one where they took adults who have asthma, and they compared their dust mite exposure to their FEV1, or the measurement of how much they're able to breathe out in that first second, which is a way that we kind of use to establish if this is mild, moderate, severe asthma, stuff like that. So it's not, you can see like the scatter plot isn't quite as tight as the one on the left is, but still there's a general trend where the more dust mite exposure you have, the lower the FEV1 you have, and therefore the worse your asthma can be. This is that study that I talked about from Yale, which we'll actually talk about this with cat and dog as well. But it was a pretty good-sized study where they took 450 kids with asthma, and they took dust samples from their living room, bedroom, and mattress, and measured the amount of allergen in the dust itself, and kind of divided them based on how much allergen, each specific allergen was in that dust. And then they took the kids and they did skin testing and blood testing to kind of determine if they were sensitized or not sensitized. And it was pretty interesting for, and then with that, they kind of looked at the severity of asthma. It was pretty interesting for dust mite, which at the lower concentrations of dust mite, so on those two, groups on the left of each one of these, for the lower concentrations of dust mite exposure, they showed that if you are sensitized to dust mite and you are in an environment that has dust mite, you have a higher, there was a higher percentage of kids who had more, severe asthma, so moderate to severe asthma as opposed to mild. The interesting about dust mite on this one is that they actually found for the higher concentrations, so once you get above a, 2 mic per gram concentration of dust mite allergen, it did not matter if you were sensitized or not. So that's what you can kind of see with the different bars that are on that bar graph, where once you get to those higher concentrations, whether you were sensitized or not sensitized, there is the same percentage of kids with moderate to severe asthma. So what this, and this is just one study, but what this would suggest is that at higher concentrations of dust mite, there is, dust mite drives asthma independent of allergy, so it can actually drive a bit of a non-allergic asthma phenotype as well, which is unique to dust mite. So this would argue that, everyone should do dust mite precautions because it still has that potential to drive asthma. And as far as dust mite precautions, that sounds great, but what the heck is dust mite precautions? It is a lot of different things that can be done for that. So for dust mite precautions, all those things are kind of on the left. You can, we would generally encourage you to wash your sheets and blankets every 1 to 2 weeks, if not even more frequently than that. Washing the stuffed animals as well. There's not as much data supporting that. It's kind of more weak data. Yes, it's great to remove the carpet and drapes, but patients often ask me, like, do I need to remove the carpet in the bedroom? I mean, yes, that would be ideal, but that's not exactly a cheap fix and is not always a feasible fix, especially if you're renting. Please do not tear up the carpet in your bedroom. Your landlord will frown upon that. Yes, we encourage you to vacuum twice a week, but the problem with vacuuming is we talked about how these particles get aerosolized. So when you're vacuuming, you can actually, stir up those dust mite particles, and they'll stay up for 20 or 30 minutes and can actually cause some worsening problems. So because of that, it's ideally maybe not the dust mite allergic person is one at, vacuuming, maybe somebody else, or wear a mask while you're doing it. HEPA filters work great, but really the things that have been shown to work the best is, sure, you can decrease, do like a dehumidifier to decrease the humidity under 45%. But the problem is that most of the people who have dust mite issues also have nasal issues, and if you drop that humidity enough, you will make their nasal issues worse. And that's why the biggest thing we harp on for dust mite precautions is mattress covers and pillow covers. The image on the right is a kind of a, electron microscopy looking at the different options for covers. So picture A and B are, like the top two, are looking at that finely woven dust mite mattress cover. And you can see in the picture on the right that those fibers are pretty airtight, and there's not much space to get through, which is what the picture on the top left is, that gross picture of a dust mite trying to get through that mattress cover, and it's not able to because there just aren't any holes. The picture on the bottom left is an electron microscopy of a cotton sheet. So you can see that those fibers are all over the place, and there are some nice big holes, and that's why that cotton sheet does nothing to keep that dust mite from causing problems. The one on the bottom right is they looked into doing, instead of like the finely woven materials, doing more of like a heat pressured material to kind of like heat seal it, which it's still better than the cotton sheet, but it doesn't, you can see it's kind of more haphazard with the way those fibers are aligned. There's still some holes and pockets in there. And that's why like the proven thing that you see is like the mattress covers and pillow covers. Those things can be bought anywhere. They can be, you can get them from Amazon, Walmart, probably Bed Bath & Beyond, things like that. You can just, like all things in life, look for the cheapest option that has the best review, and that will help. Moving on from dust mite, we're going to move on to the other, kind of more, ubiquitous allergen, which is cat and dog. So these particles are much smaller than dust mite, and because of that, they can be passively transferred. So they've done lots of studies looking at, what's the percentage of cat allergen and dog allergen, percentage of American homes where you can detect that. And it is as high as 95 to 98% of American homes have these things detectable. It does not matter if you have the pet or not, because there is so much passive transfer. Now, yes, if you have the pets, there's 100 times higher amount in those homes. But there is something to be said about, if you are cat allergic and you go to work and you sit next to the crazy cat lady who has 20 cats at home type thing, and you feel like your allergies are getting worse, there is actually something to that, because there's just a lot of passive transfer. Which leads me to one of my favorite studies. It's just a really creative, cool study design. This came out of Sweden, where they took 90 kids who had asthma and a cat allergy but no cats at home. They did peak flow measurements during the summer before they went back to school. And then they went back to school, and half of the kids went to a cat high classroom and half went to a cat low classroom. And what they defined that was, if more than 18% of the kids in the class had a cat, that was considered a cat classroom. Like a high cat classroom. So 18% is not that high of a cutoff, but still, this is kind of just like really checking the effect of like passive cat exposure on asthma. And they actually detect 5 times the amount of FeLD1, which is like the predominant cat allergen in that classroom. And this is what they found was pretty impressive results. So these 4 graphs are kind of looking at peak flow. Everything is done 2 or 3 weeks after they've started school, and they've checked these kids' peak flows, their asthma symptoms, their albuterol usage and their inhaled corticosteroid usage. And the short version is everything got worse in the high cat classroom, and it got like a lot worse. There was that 9-fold increased risk of asthma worsening in the high cat classroom versus the low cat classroom. Which, this is again that Yale study. This is kind of just really hammering home the fact that, like, you know, for a cat, if you're allergic and you have asthma, it can cause problems. So on the left is the cat, on the right is dog. And for both cat and dog, they were able to show that in that same study where they look at, you know, house dust and kids that are allergic to them, if you are allergic to cat or dog and you are exposed to cat or dog, you are more likely to have a more moderate or severe asthma than if you were not. So that sounds great. What do we do about it? Which you already know the answer to this. You know, it's, you can remove the pets, which not everyone is a big fan of this answer. And patients often ask me, like, you know, do I have to get rid of my cat or dog? And it's like, well, if your asthma is mild and we can control it, it's okay if you want to keep them. If it's more severe, I mean, we really got to look at, you know, getting rid of the animal type thing. This was a small study, but this study has been kind of like shown in other things. They took 20 adults with pets and allergy, 10 got rid of the animal, 10 kept the animal, and the animals they had on this pet was actually cat, dog, and I want to say it was hamster as well was on there. It wasn't all just cat and dog. But out of the people who removed the animal, 5 of the 10 were on inhaled steroid at first. 1 year after removing the pet, none of them were on steroid. Whereas in the group that kept the pets, again, about half were on an inhaled steroid afterwards, and almost all of them were on inhaled steroid after a year. So you can see that when you remove the pet, it really doesn't just improve your asthma, it actually decreases your need for asthma control medications. Whereas if you keep it, it might actually make your asthma more severe and drive up that need for an asthma control medication. As far as other options you can do, having a HEPA filter, like if you're going to do an air filter, it needs to be a HEPA air filter. It's debatable. There are some studies that show that it works. There are some studies that show that it does no difference. My opinion on it is that it's not going to hurt anything. You know, if you can afford to get a HEPA filter, go for it. It should be definitely in the bedroom and probably in the living room as well. But it's not a guarantee to make things better. As far as, well, can I just wash them a whole lot more frequently? Sure, and there's actually, you know, studies that show that it does help. That's what the studies on the left show, on the right show. You know, one is with cat, one is with dog, where if you wash them more frequently, you will reduce the amount of allergen that they shed. The problem with that is that it works really well for like 2 or 3 days. So in order for you to just wash your pet more frequently, you really need to be washing them like twice a week, if not 3 times a week, to have a sustainable effect on the decrease of allergen that's present. And when they did the study on the cat, they actually took buckets of water and they like submerged the cat under the water and then kept neck down under the water for 3 minutes. And after that, did 3 minutes of vigorous scrubbing with the cat before they got the cat out, and that's what showed that they had improvement of cat allergen. So clearly these people don't own cats, because I just don't see how that's a feasible option going forward. Another interesting thing that I saw after I'd already made these slides, there's actually a new cat food, I want to say from Purina, that actually does something, because that FeLD1 cat allergen is more present in their saliva. So there's now a cat food that actually decreases the amount of FeLD1 in the saliva, so it can actually decrease the cat allergen you're exposed to, which is crazy, but they apparently have data proving that. So I haven't looked as much into it, but it's something where if you have a cat, it would not hurt anything to change the cat food over. As far as what if you're just like exposed to a massive amount of cat, this is also debatable. There are some studies that don't show this, but this is a good study from Platts Mills, who is an allergist out of Virginia, University of Virginia. He's a pretty big deal in the allergy community, where he looked at cat allergen exposure and the incidence of sensitization versus an IgG level, which IgG is actually protective against allergy. And the short version of this is if you get exposed to whopping amounts of cat, which if you look at that percentage on the concentration on the right, it's 106 to 3,800 mics per gram, which is a massive exposure. you are more likely to be, not sensitized than sensitized to cat. But it's pretty large amounts for that, which this kind of makes sense because it's the same idea behind us doing allergy shots, or if I expose you to a much larger concentration, eventually you become desensitized to it. As far as pollen triggering this, we're not going to talk that much. This is my only slide on pollen because pollen doesn't seem to really drive the development of asthma. Now, if you are pollen allergic and have asthma, sure, it can absolutely make that worse. This is the, pollen forecast that we actually have on our website, where it kind of breaks down, trees, weeds, and grasses by the individual tree, weed, and grass itself, and kind of show what months of the year it's higher at. It's on the slide. You can go on our website to see it as well. But the bigger thing is, like with this, yes, if you have a big tree allergy and you are very allergic, when your tree allergies spike, your asthma can spike as well. So as far as prevention, the name of the game nowadays in medicine is to try and prevent as opposed to just reacting. So when you react, we're often too late. So they've looked at a lot of different studies trying to see if we can't prevent this. There was a large cohort study out of Australia where they took kids who have a family history of asthma or a family history of asthma, and they see if they had a cat or dog prior to age 5 and kind of follow them up until age 5 to see if it has any effect on allergies and asthma. And it does decrease the incidence of cat and dog allergy, which is awesome. However, there was no apparent effect on the incidence of wheezing, eczema, or asthma at age 5. There was a Canadian study where they actually got a little more technical with it and looked more at the microbiome of kids who have pets. And they're able to look at 2 specific bacteria that seem to be protective against asthma and allergic diseases. And it seems like in kids who grew up with pets have a higher percentage of that bacteria, and when in doing so, they have more protection and therefore a decreased asthma risk. So you can see there's a little bit of, disagreement amongst those 2 studies. Like yes, having pets will definitely help you not be allergic. Hard to say if it has an improvement on asthma risk. There are a lot of other studies that show that having more siblings and more pets reduce asthma risk. But there's the question of, well, is having more pets reducing asthma risk? Or is it just that if you don't have asthma, you are more likely to have more pets because they don't give you problems? There's that issue of bias, so it's hard to say. They have looked into trying to actually treat kids to try and prevent asthma. So look at, my favorite 2 medications as an allergist. So on the left you have corticosteroids, on the right you have antihistamines. The short version is that on both of these, they were larger studies that took a bunch of kids and started them on either the ICS on the left at ages 2 or 3, or just, cetirizine or levocetirizine on the right at ages 18 months. And they kept them on that for a couple of years and looked to see if there was any difference in the incidence of asthma, and there wasn't. So you can pound them with cetirizine and, an inhaled corticosteroid, but at that point in time, you're just giving them medication for the fun of it. It will not actually prevent asthma based off of these studies. And there are other studies that show this as well. So what about shots? Shots do seem to work. So there's a lot of studies on this. This particular one that I chose is out of Germany, where they took 180 kids who are grass or birch tree allergic, ages 6 to 14. They did 3 years of subcutaneous immunotherapy, which is just allergy shots, and they compared it to people who were on medication. So it wasn't just comparing it to placebo, and they actually had significantly less asthma 5 and 7 years later. So putting them on shots can actually halt that allergic inflammation, and in doing so can kind of prevent all of the development of that Th2 inflammation in the airways of these kids. There's another way to do, allergy immunotherapy, which is drops or sublingual immunotherapy. This is how they do things in Europe a lot. We do it in the US as well. It's just not FDA approved. With some, the general drops are not approved, but there are some sublingual tablets that are FDA approved specifically for ragweed, grass allergy, and dust mite. But basically, they took 60 kids and they compared drops to medications, and it was a similar effect where they had a decreased risk of asthma 5 years later. Now, for both of these things, The studies would say it has to be done for 3 years. Most allergists would actually say it has to be done for 5 years. It has to depends on that, longevity of symptom. Like for rhinitis, if you go to 5 years, 80% of people will not have their symptoms come back for at least 10 years, if not longer. So again, but it's that long-term treatment to prevent development of asthma. And we're going to come back to that. Actually, no, we're going to do this one right now. So as far as how does it work? There's a few different ways that it does it. One is we talked about Th2 inflammation over and over and over again. But if I were to give you a big dose of these allergens, it actually changes that kind of inflammation that you have from Th2 over to Th1. So if you think back to that slide, that's why at the bottom of Th1 I had protective, at the bottom of Th2 I had allergy, which is also what that figure from the article from Platts Mills and his colleagues shows as well, is that protective is that high IgG, whereas sensitized is an IgE. So it shifts you away from that allergic inflammation over to that Th1 inflammation, which reduces asthma symptoms. It will also reduce polysensitization. So if I take a kid who is allergic to dust mite and put them on shots right away, they are less likely to develop more allergies. Whereas if I don't, they are more likely to kind of slowly acquire more allergies as they get older. I think. So as far as, and we'll come back to the treatment in a second, but as far as for preventative, who to do this on, as you can imagine, it's pretty hard to take a kid who has, a runny nose with cat and tell them, hey, let's give you 5 years of allergy shots because you might develop asthma one day and this will prevent it. So there is this, asthma predictive index that you can kind of use to predict if they are more likely to develop asthma. You can look over this yourself, but the short version, there is some criteria that are on here. There's the regular asthma predictive index, and there's the modified. The modified is a little bit more, restrictive. The modified is where you have 4 episodes of wheezing as opposed to 3. The modified also just changes it from just allergic to rhinitis to any sensitization to an air allergen by skin test or by blood test. This is something that can kind of help you predict if a kid is going to develop asthma. It is it's pretty specific. That specificity is in that 70 to 85%. Which is not that high, but that just kind of shows that it is hard to predict if a kid is going to have asthma. But still, so you're using that where if they have positive, it will make you more likely to think that they will develop asthma. The sensitivity is not great. It's like 30 to 40% sensitive. So again, that negative predictive value is not great. So if they don't fit this criteria, they still could develop asthma, which is why you're really using this to try and see, should you put somebody on shots to prevent? As far as once they already have asthma, you can absolutely use allergy shots or allergy drops to kind of help improve their symptoms. There are some studies, there's lots of studies showing that both shots and drops are effective. There are equally many studies showing that shots tend to be a little bit more effective than drops. Both of them will decrease asthma symptoms. Both of them will decrease their medication usage, so you can actually have, lower need of maintenance medications. The issue, though, is 1, it's not fun getting shots. 2 is that, there is that higher risk. So there is a mortality that, there have been fatal reactions to shots. It typically happens in more severe asthmatics. There have not been any mortalities in drops. Again, and for the risk of that reaction, with standard build-up protocols with allergy shots, there's a risk of reaction of 0.1 to 0.2% per shot. So it's a very low risk when you go slow, and we're not, if somebody is more high risk, we're usually not just jumping to shots. But this will help with asthma treatment. Not only does it help with asthma treatment, it can also reduce your asthma medication. So there's a study that shows there's a good role for this in that asthma step down, because if you think through like your asthma guidelines where you have that step up therapy, once you're controlled, you're trying to step down. This can help you with that. Now, it's not going to help you for that mild persistent, because if they're on an inhaled corticosteroid, there's not much more room to step down. But if they're in that step 3 or step forward, which is your moderate persistent or severe persistent, you can reduce their ICS usage, their ICS doses, maybe decrease them from an ICS LABA combo down to an ICS monotherapy, but it really can help you back down off of their medications to try and reduce their long-term exposure to those medications. And it works by desensitizing. So we've kind of talked about this already. It shifts that that inflammation over to that protective kind of inflammation. And in doing that, there was a study where they actually used, other testing to kind of prove that there are physiologic changes in the inflammation that gives you that long-standing effect. So the short version is that it helps you with airway remodeling, and it does that where they actually looked at FeNO, which we mentioned before, where it's increased production with more inflammatory cells. Well, it decreases with allergy shots, so you're having a decreased presence of eosinophils and inflammatory cells in your airway. They also looked at CT scans for the airway caliber and wall thickness, which is a pretty creative way to use CT scans. And they actually showed that when you've been on, slit for dust mite, that you have increased airway caliber, so the airway itself is, more open and bigger, with decreased wall thickness, so you're kind of reducing that airway remodeling right there, which is pretty cool that it works that way. And yes, it definitely, with all of that, improve airway remodeling. We're not just helping out a CT scan, it actually does improve your symptoms and your FEV1 as well. And this is the last thing we're going to talk about. I'm not going to talk very much about biologics, because if you're interested, I know that there was another lecture given, I believe, last fall by Dr. Magruder from from Children's, where she actually goes through all of the biologics that we can use for asthma, and she does a great job with that, so we're not going to hammer that home anymore. But specifically for omalizumab, this is the one biologic that is really geared for allergic asthma. Even though your anti-IL-5s are used in eosinophilic asthma, there is not a requirement for allergy to use those. But for omalizumab, there is. So omalizumab is a monoclonal antibody against IgE. It is approved for asthma ages 6 and up. The slide is actually wrong on this, so that is my bad. The IgE needing to be between 30 and 700 is actually for age 12 and up, for what it's worth. For ages 6 to 12, the IgE has to be between 30 and 1300. Honestly, though, that's really something that's more important for me to know. If you're primary care, it's not really as important for you to know those specifics, because really I'm the one starting the patient on this. But to hammer home that this is for that allergic kid, the other criteria is you have to have a sensitivity to a perennial allergen. So that would be cat, dog, dust mite, cockroach, things of that nature. There is an anaphylaxis risk with this, but it is 0.1 to 0.2%, so it is not a huge anaphylaxis risk. So it is approved for asthma. It's kind of in that step 3, step 4 range, where it helps with that moderate to severe persistent asthma. It works really well. The other time that we can use this is if you have a kid who is, or an adult, who is in that severe allergic asthma, and you know that if you were to give them allergy shots, they would get better, but you're nervous about doing allergy shots because of the degree of their allergy, and it's a high risk for a reaction. There are studies that show that you can use omalizumab and allergy shots at the same time, and the omalizumab drops their reaction risk. So you can kind of use omalizumab during that build-up period to get them to maintenance on their shots, and then once they're on maintenance and they're tolerating it, you can drop the omalizumab and they can keep rocking and rolling on the allergy shots to again reduce their medication dependence. And with that is all I've got. So kind of going over this, very briefly, if you've been drifting off during all of the, biochemical and physiologic type slides, if you just look at this one, this kind of is the nuts and bolts of it. So allergic asthma is, again, it's sensitivity to an allergen as proven by either a blood test or a skin test, and correlating symptoms that go with that. While all allergies can trigger asthma exacerbations, it looks like, dust mite and pet sensitivity And actually cockroach and mice in more inner city locations, I didn't really go over that data as much, but those more, year-round perennial allergens can actually drive the development of asthma and are like independent risk factors for development of asthma. If your allergies are uncontrolled, your asthma can be a whole lot worse. That does not mean that giving somebody cetirizine will control their allergies, but giving somebody allergy shots to kind of treat allergies at the root cause of it can make their asthma, better. At the same time, having their, allergies that are rampaging year-round or during spring and fall will absolutely make their asthma worse at that time. In addition to immunotherapy, there are also lifestyle modifications that reduce asthma risk, such as dust mite precautions. If you're cat and dog allergic, not having a cat or a dog. With pollen seasons that they trigger it, maybe not going outside on high pollen days. The short version is, tree pollen is in the spring, grass pollen is in the summer, weed pollen is in the fall. But for what it's worth, on our Alabama Allergy website, we always do at the top of the website have those things and say if the pollen is low, high, or moderate. And with that, just a few references, probably overkill on the references. But normally I would say, do you have any questions? But it's easy for me to say that when there's nobody here to ask the questions. So if you have any questions, feel free to reach out either to me if you know me, or to the Alabama Department of Public Health. They can reach out to me and we can get those answers back to you. And with that, have a great day and thanks for joining us.